Hello everyone, I am Dr. Vidhi Patel, second year resident in Radiology Department, Shah Medical College and Hospital. I am presenting a case in a case of the week series. 30-year-old female with 7 months of amenorrhea presented to our department for routine antenatal checkup. No significant family history was present, no complaints in present or any past pregnancy. USG finding reveals evidence of reduced anteroposterior diameter of thorax suggestive of pectus excavatum. Cleft lip and cleft palate noted. Bilateral deformed wrist joint anomaly noted due to hyperflexion of both wrist joint. Following image shows flexed wrist deformity. USG image shows right normal foot and left club foot, as club foot is the common skeletal anomaly affecting the foot. MR image shows deformed wrist joint with larger fetal head suggestive of macrocephaly. MR image shows a large posterior fossa cystic lesion with associated malformed and hypoplastic cerebellum which is pushed anteriorly and inferiorly. There is elevation of tentorium cerebelli noted, smoothing of cerebral hemisphere with reduced number of sulci noted, possibility of a migrational disorder, lysencephaly more likely. Agenesis of corpus callosum with colpocephaly noted. Patient delivered at 32 weeks of gestation and the clinical picture shows macrocephaly, left clubfoot and wrist deformity. Clinical picture shows evidence of pectus excavatum, cleft lip and cleft palate deformity. It also shows loss of normal curvature of spine suggestive of multiple spinal deformity. Findings suggestive of posterior fossa cystic malformation, Dandy Walker malformation with Chiari2 malformation more likely. Discussion. Dandy Walker syndrome is the most common posterior fossa malformation. Clinical presentation is dependent on the severity of abnormality. The estimated prevalence of Dandy Walker malformation and related variants is about 1 per 30,000 live births, which accounts for 7.5% approximately. Patients usually manifest in the first year of their life with the symptoms of hydrocephalus and associated neurological symptoms. Macrocephaly is one of the most common manifestations. Classically, Dandy-Walker malformation consists of the triad of 1. Hypoplasia of the vermis and cephalhead rotation of the vermian ruminant. 2. Cystic dilatation of the fourth ventricle extending posteriorly. Usually, the cerebellar hemisphere are displaced anterolaterally but with a normal size and morphology. Third, enlarged posterior fossa with torcular lambdoid inversion. Torcular lying above the level of the lambdoid due to abnormally high tentorium. A Dandy-Walker malformation carries a high mortality rate, approximately 70% in live-born fetuses, often due to associated abnormalities. It is thought to carry a poorer prognosis if diagnosed prior to 21 weeks of the gestation and better prognosis if diagnosed postnatally. The prognosis depends on the severity of brain malformation, cyst, and fluid buildup level. A cystoperitoneal shunt should be considered in a situation where hydrocephalus is a significant problem. Treatment for Dandy Walker malformation is generally focused on the symptoms, for physical therapy to support the motor development, occupational therapy to build self-care and mobility skills, specialized education for cognitive and learning problems. Speech therapy is considered for speech and language development.